a panel of clinicians from both who've both worked in either Alaska or in Pine Ridge, South Dakota. And I know there are also some other global rural health fellows on the call, but really wanted to just get kind of a panel of experiences from people who have been working in other rural underserved areas and draw parallels with some global health experiences that they've had. And so I know we have Andrew McGinnis, who's going to give he's on service, so I wanted him to give his kind of brief introduction to his experience. He's in Alaska. I don't know if we have the other panelists on, but Andrew, why don't you go ahead and introduce yourself, and then if the other panelists are on, we can have them all introduce themselves, and then we can go into your kind of brief presentation. And then we'll also have a presentation from Joyce Achin-Chang about Pine Ridge. And then we'll kind of open it up to the panel and have some discussion.
Yeah, thanks a lot, Sam and Lauren. So as she said, my name is Andrew McGinnis, and I had Sam's job a couple of years ago. And then I decided I wanted to continue a career in global health education, but I didn't really know how to get a job doing that. So I decided to do the Global and Rural Health Fellowship. And also the idea of living in Alaska was really appealing to me. And so I just finished 9 months in Liberia. I had to come home a little early because of the borders shutting down with COVID. And so now I'm back up in Alaska, and I've taken a hospitalist job up here while I continue to work on some global health stuff on the side. So thanks a lot for having me.
Great. And I think I saw Kyle Pohl had hopped on. Kyle, do you want to introduce yourself?
Sure, thanks.
Great.
I'm Kyle Pohl. I'm an internal medicine and pediatric physician in Alaska. I've been working up here going on 5 years now. I work as a dual hospitalist in Anchorage, and I spend about 50% of my clinical time out in rural Alaska, primarily in Nome, doing public health and primary care.
Great. Thanks so much for joining. Let's see. I think I saw Megan hop on. Megan, do you want to introduce yourself?
Hi there, I'm Megan. I'm from Northern Virginia. I did med school and residency at Georgetown and then came out to UW for the Global and Rural Health Fellowship, which I finished in 2019. And so came up to Anchorage with that program and worked out in Bethel, and then went to Kenya for my second year and worked primarily doing medical education and clinical work in Nakuru, Kenya, and then also returned to Alaska after I finished fellowship and work as a hospitalist at A&MC.
Oh. Great. Sorry, did everyone hear that? Lauren, you said there was muted. Okay, great. Awesome. I think, let's see, I know Andrea and Joyce, maybe you guys just hopped on, but do you guys want to go ahead and introduce yourself briefly?
Sure. Yeah, I can do that.
Okay, Joyce.
Hey. So my name is Joyce. I am currently a second year rural and global health fellow through UW. I'm not sure what I was supposed to say, but I did internal medicine at St. Louis University and then came on to the fellowship. So last year I did a year of hospitalist work in Pine Ridge at the reservation in South Dakota. And now I am home figuring out my second year, possibly going abroad, trying to figure out that part. So yeah.
Great. And Andrea?
Hi, yeah, so I'm Andrea. I have now finished the Rural and Global Health Fellowship, but I preceded Joyce at Pine Ridge. And then after that, so last year I went to Peru and I did some research in public health and like their primary healthcare system. And I am about to be starting a job in Baltimore with a hospital group called MedStar. And I'll be doing a variety of things for them in their residency program. So thanks for having me.
Awesome, thanks for joining. Yeah. Cool, so kind of the format, I wanted to give at least a little bit of background on both sites that most of you guys have worked at. And so I've asked Andrew and Joyce to kind of give respective backgrounds on Alaska and Pine Ridge. So Andrew, I know you're on service, so I'll have you go first, and then we'll open up afterwards to the panel and discussion.
Cool, thanks, Sam. Should I just like share my screen for the slides? Is that the best way to do
Yeah.
this?
Yeah, I think so.
Okay. Sorry, give me a second. Are you guys seeing PowerPoint?
Yep.
Looks good.
The wrong page. Okay. All right, cool. So yeah, as Sam said, this will be just a really quick overview, and Megan and Kyle have more experience working in the system, so they can feel free to chime in or add things at the end if there's any updates needed. And it's really hard to cover a whole statewide healthcare system in such a brief time. So my focus of this was to try to help you guys understand what it's like to be a patient in Alaska, in the Alaska Native healthcare system, and maybe try to draw some connections between that and the kind of work that we do in global health. And that may fall more into the discussion at the end. So just as a brief overview, this is like the Wikipedia page condensed onto one PowerPoint slide. So I work at Alaska Native Medical Center in Anchorage. It's the main referral center for something called the Alaska Native Tribal Health Consortium. And this is a statewide organization that was created in the end of the 1990s to streamline the process for a statewide referral system and to provide some statewide coordination for these independent regional health organizations. And so the regional health organizations provide care in their rural setting, but it was realized that they needed some shared resources on a statewide level. And so they're equally represented on the board of ANTHC, which tries to be that referral system and center. And so as an umbrella organization, so I mentioned it's tribally owned and operated, and this is one of the things that I think sets it apart from a lot of IHS sites. And one of the reasons the Alaska Native system is so successful. It's something that people are really proud of here. And then it serves a population, to us, about 200,000 people seems like a big population for Alaska, but I know compared to Seattle, that's like small change. It's Alaska Native and American Indian patients living in Alaska. ANTHC has 3,000 employees. And again, that's just the statewide organization. So these individual rural health entities have their own employees locally, but they're one of the largest healthcare employers in the state. They help coordinate care across 170 village clinics, which are staffed by 550 approximately community health aides and community health practitioners. And so this is one of the things we'll focus on talking about in terms of the connection to a global health type setting, which relies a lot on community health workers as well. So then these 170 clinics refer up to 58 tribal health centers that have slightly more medical resources. They might have maybe an x-ray machine or IV fluids or things like that. And those refer to 6 regional hospitals scattered across the state. And when the acuity is high enough or specialty care is needed, they all refer to us at Alaska Native Medical Center. So kind of like a pyramid of a care system. And I think I like this image. It's a little pixelated, but hopefully it helps to illustrate like how complex the system needs to be. And so even though there's only 180,000 patients we serve, you can see the space occupied by the state of Alaska. It's overlaid on the US here. From Southeast Alaska to the end of the Aleutian chain is the same distance from Florida to California. And so this population is spread in a huge area and sometimes living in villages as small as 20 or 30 people. And so you have to figure out how are you going to get access to healthcare to people that live in a village with no road access and too small of a population to justify sending a long-term healthcare provider like a PA or an NP or an MD into that community. The red lines on here are the common flight paths. And so they're all starting out in the peripheral villages. They're converging on the regional hubs and the regional hospitals. And then the middle star where everything's converging in the center is Anchorage, is ANMC, where a lot of these flight paths end up bringing patients. And so the way that this is accomplished, this is just a slightly less busy picture of the same thing. The red dots are showing you all of the village clinics in Alaska that are maintained inside of this system. This picture was taken from the Community Health Aid and Practitioner website. So they're highlighting the areas where the community health aides are trained as well. And again, I think it helps to give a sense of the scope. The difference between the community health aides in Alaska and the community health aides you may be familiar with if you've done global health work is that in Alaska, they're not only assessing patients and helping them get access to care, but a lot of times they're actually providing the first line of care in conjunction with a provider. And so a patient will come in with a complaint. The community health aide has something called the Community Health Aid Manual that's divided by organ system. So it's a respiratory complaint. They'll go to the respiratory section. They'll triage the patient and decide, is this an emergency? Do I need to call a doctor right away, or can I go through some algorithms with them? And if they're relatively stable, they'll follow an algorithm to a diagnosis, come up with a plan, and send that plan along through the EHR to a doc for approval. And if there's approval, a lot of times the medications can be given in the village without the patient ever leaving. It's a really cool system. I think I mentioned that one of the things that helps this to stand aside from other IHS sites is that it is tribal owned and tribal operated, as opposed to IHS owned and IHS operated. The other thing that sets it aside is that we're relatively wealthy compared to other IHS sites. And this financial summary from ANTHC, just the circle on the left, I think highlights that only about a quarter of the money that operates this hospital comes from the IHS funding. The patient revenue, it's a free care system. The patient revenue is from Medicare and Medicaid billing. And then there are other sources of income from statewide resources, grants and projects, and investments and things. On the right, you see there's like only a tiny bit of spending for community health, but remember, this is the statewide ANTHC, so the individual tribal health organizations are spending a lot of their budgets on their individual clinics, so that's not quite representative of how much money goes into community health. So let's see, how are we doing for time? Maybe 5-10 minutes left. So I'm going to try to walk through a case because I think that's the easiest way to understand like really how complex and how community oriented this system is. And then I'll stop there and take just a few questions, and then we can discuss more later kind of the intersection between I think the global health and the rural side. So this case was written pre-COVID. I put this together pre-COVID for another talk. So pretend COVID-19 doesn't exist. If there are any kind of social medicine junkies or medical anthropologists in the audience, you can imagine how much more complicated this gets when you have to include testing for an infectious disease in a teeny tiny community of say 50 people, where there's a lot of stigma surrounding COVID and COVID diagnosis, and a lot of denialism too, because of the fear that a diagnosis would bring to you. So we're not going to address those issues, but I think it's another really interesting part of our job is the social side of things. Okay, so I'm going to kind of just rush through this. It's not very interactive, but hopefully it helps give some insight. So a diabetic patient, she's coming in with 3 days of fevers and cough, and she lives in a little village called Tanunak on the west coast in the Yukon-Kuskokwim region of Alaska. Initially, when she comes in to see her village health aide, her vitals are relatively stable, oxygen is fine, blood sugar is okay. And so based on the initial vitals and triage, the health aide knows that they can go through their CHAM, their Community Health Aid Manual algorithms. And based on the questions they ask in the exam that they do and what they've heard, they suspect that the patient probably has a viral URI. So since this is a low acuity case, what they'll do is they'll type up a note in the electronic health record and they'll send it to the regional hospital. In this case, the regional hospital is Bethel. And they call this radio medical traffic because historically, before EHRs, this was literally done over radio, over like a CB radio, and the whole town was listening in to the presentation between the health aide and the provider. Nowadays, it's confidential and it's through the EHR, but Bethel will have a provider or two on radio medical traffic for that region, going through every single patient visit and looking through the questions that were asked, the exam that was done, the health aide's assessment, and they'll decide if they agree with the assessment to approve whatever the proposal was. So in case of a URI, it might be to give Tylenol and some Flonase, and they might say, yeah, that sounds reasonable, I approve that. If they have any questions, and in this case, the provider looking through the case felt, well, the patient does have some risk factors, the heart rate's a little high, I want to make sure to get an x-ray because they're more having cough and not so much upper respiratory symptoms. So just let's rule out a bacterial infection. In this case, they want to use the least resources possible and the least travel. And so they're going to look for where's the nearest place the patient can get an x-ray done. And so I have a little map in the corner. Bethel in black. So we're just seeing the villages that are served by the hospital in Bethel, the Yukon-Kuskokwim Health Corporation service area. In the center of the black dots is Bethel, where the hospital is. And to the left of that, in the purple, you can see Tununak all the way out there on the coast up top. And just below that, there's a big circle at Tuksuk Bay. The Tuksuk Bay is the regional health center, the sub-regional clinic, and they have an x-ray machine at Tuksuk Bay. They have a kind of mini E1 cot in it to stabilize traumas. They have IV fluids and a small range of medications. They can draw labs there. They don't have the machinery to process most labs, but they can draw them and put them on an airplane. So the patient travels the 20 miles from Tununak over to Tuksuk. In the summer, that would probably be on an ATV, and in the winter, that'd be on a snow machine. And there's a physician assistant at Tuksuk Bay. So Tununak has about 50 people in it, and Tuksuk Bay has about 500 people living there year-round. They service an area of a few thousand people with all of those villages in purple put together. And so they're able to afford a physician assistant year-round in that clinic. And so the PA sees the patient, the PA shoots their own x-ray, which is kind of cool. They're pretty much alone with other health aides. So they shoot their x-ray, they send off the images, and it looks like there might be a focal infiltrate. They draw labs. The labs can't be accessed right away, but they can be sent out on a plane and they can have the results back the next day. The patient's vitals are still stable at this time. And so they, in communication with the provider in Bethel, the PA decides patient can go home. They'll start amoxicillin and they encourage, hydration. They ask the health aide to check in on the patient. So either check in clinic or just literally walk across the street to the patient's house and check on them 2 days later. So the patient goes back to Tununak. 2 days later, the health aide checks in with them, and now they're having a harder time breathing. Their oxygen sats are going lower, and they're still working on a fever. So because now the vitals have changed, the health aide at this point, instead of going through a long algorithm, will get directly in touch with a provider. The on-call provider in Bethel has a discussion with them, and they need to decide, okay, the patient needs a higher level of care, they're not getting better. Do we put them on a commercial flight, so the next flight tomorrow in a normal airplane, or do we mobilize the funds to send a medevac out to evacuate this patient and bring them in to the hospital? In this case, with the hypoxia, they decided the best thing to do was to put them in a medevac on oxygen in case they were to decompensate. And so back to the map on the bottom left, a medevac is dispatched. It lands in the airport in Tununak, picks up the patient, and brings them back to Bethel, the nearest hub for stabilization. And this is an important step, the regional stabilization, rather than directly sending somebody from the far regions to Alaska Native, because you don't want somebody to, for example, need to be intubated in the middle of a flight. That's like a worst case scenario. So in this case, the patient did get to Bethel. They are on oxygen. They're able to get a CT scan there now. There's a CT scanner in Bethel, no MRIs, no specialty care, but they do have a CT scanner. They're giving antibiotics, fluids, oxygen, and the patient becomes unstable and ends up needing to be intubated. The hospital in Bethel doesn't have any ICU level care. So patients that need intubation, they get intubated in the ER, and the ER docs, a lot of whom are family medicine providers, then manage the patient until transportation can be arranged. And in this case, then they call the Alaska Native Medical Center, call to the ICU for transfer of a patient for higher level of care. So then another medevac is arranged from Bethel to Anchorage. So now 3 or 4 days down the line and 5 provider visits later, the patient is medevac to ANMC ICU, and they manage her for ARDS. She responds very quickly. She's extubated after 3 days and has a good clinical outcome. And so at this point, they call us to write a discharge summary for the patient. And at this point, we have the option, instead of sending somebody who's just had a critical illness straight back to a small village without running water, we have the option to keep them in town here. So we have something called patient housing, which is essentially a nice hotel on the campus here, where even though the patient doesn't need hospital care, we can keep them close in town for specialty follow-up. So they can see an internal medicine doc, they can look at insulin titration post-discharge now that they're not eating a hospital diet, get them up to date on any kind of follow-up or specialty care they need after their hospitalization. And then when they're ready, within a few days or a week, then we can arrange a commercial airline back to their hometown, ideally. And what we strive for is to have some closed loop communication with the community health aide. So call them, let them know what happened, ask them to check on the patient in a few days for X, Y, or Z follow-up. And either the discharging hospitalist can take responsibility for that, or the outpatient provider who sees them and follow up locally. Okay, so hopefully I did that quick enough. So that's just, I think, I wanted to take the perspective of a patient's experience to get a sense of how kind of complex, but also I think really cool and community oriented our approach to care is up here.
Awesome. Thanks, Andrew. Yeah, I think we'll kind of leave some of the questions and discussion for towards the end. So I wanted Joyce to give a quick presentation on Pine Ridge, and then we'll kind of open it up.
Hey Joyce, you're on mute.
Yeah.
There we go.
But we can see your slides, they look great.
You can hear me now though, right? Okay, good. So my experience a little bit different from Andrew's in terms of how medicine's done in Pine Ridge. So mine is a very, very brief oral health experience from my perspective on Pine Ridge. So I was there for a year, like I said, doing hospitalist work. Let's see. Okay, so before going, I didn't know where Pine Ridge was, to be honest with you, but this is where it is on a map. It's a reservation in South Dakota. I have a few pictures and a little bit of some data to explain it. So very rural, which was also a little bit of a new experience for me. It's where the Ogallala Lakota Sioux tribe, this is one of about 573 different tribes that are recognized here in the US. Population data was a little bit hard to find. This is from 2010 was the most recent I could see. Obviously they're doing the census this year, so we'll see what that says. But there are about 46,000 enrolled members, but only about 18,000 or so that were living actually on the reservation. It's about 2 million acres or so, and it's the 8th largest reservation, but documented as the poorest in the country, unfortunately. 40% of the population are pretty young, under age 20, high unemployment rate above 80%, and a high school dropout rate of about 70%. Just a few more pictures helps to kind of break up a little bit in terms of the landscape, very plain. So in terms of some services in the community, before I get into some of the health aspects of being in Pine Ridge, churches are a big thing, predominantly Catholic churches are dominant there in Pine Ridge. They do have a college where you can get a nursing degree, which I thought was really great for such a community, and it's very thriving actually. Restaurants, not really any, mostly fast food places, no McDonald's, which was something that I found pretty interesting because you'd think you'd see a McDonald's everywhere in America, but they did have a Taco John, not Taco Bell, and a Subway actually. There's one grocery store on the reservation, which is actually pretty expensive, I think, in terms of living on the reservation, the cost of how much things cost there. So you can go to other grocery stores. The next kind of biggest city is Rapid City in South Dakota, which is about 110 miles away. And Chadron, which is in Nebraska, south of Pine Ridge, is about 50 miles away. And then the next really big city is Denver, which is about a 5-hour drive away. There was a barbershop, and they have their own jail and their own police officers for the reservation that are separate from the South Dakota police officers. No banks that were on the reservation, no motels, no laundromats, daycares, which I thought were other little essentials that you don't really think about, but can play a part in your health overall as well. In terms of some key things I noticed were these are lists of things that were at a high rate on the reservation. Depression, very common, unfortunately. Teen suicide. I'm internal medicine trained, so I didn't necessarily take care of any peds patients, but that was definitely something that they deal with a lot of on the reservation, and you see a lot of mostly in the ER. Alcoholism is a big thing, even though it is dry. So drinking alcohol is actually illegal on the reservation, but unfortunately a lot of people are alcoholics. And you see that a lot on the inpatient side too, in terms of dealing with the complications of that. Diabetes, unfortunately, is very rampant on the reservation. Through residency, the highest A1Cs I really ever saw were like 9 or 10, but here on the reservation, I was seeing 13 and 15, which, you know, really took me by surprise and was kind of changed the scope of conversation that you end up having in terms of counseling patients. And a lot of the diabetics, unfortunately, fell prey to osteo and a lot of other complications, and resulting in a lot of amputations. And then drug use, unfortunately, is very rampant on the reservation as well, mostly methamphetamine, not as much opioid in terms of heroin, like I would have actually thought, but more methamphetamine. In terms of the hospital, so this is the front sign of the Pine Ridge Hospital, and this is the front entrance of it. So provides both in and outpatient services. So on the inpatient side, it's 45-bed hospital. You do have one day hospitalist and one night nocturnist. They're not always staffed, so sometimes you do have to call on locums to come help. And that was before the fellowship was also established, where we now as the fellows were there year round. There is one OB-GYN doctor who works on for 2 weeks, and then another one comes on for 2 weeks as well. You have 2 general surgeons that have been there for 13 plus years. The ER is staffed mostly with family medicine trained physicians as well, and some ER trained doctors as well, and then PAs and NPs. There are, I believe, 2 dentists, maybe 3 by the time I left. Optometry is available as well, but no surgeries, like not an ophthalmologist, I should say. And then psychologists are available, but not so much psychiatrists, especially when it comes to prescribing certain medications. And then, of course, pharmacy, which is staffed by a lot of, I just totally drew a blank on this branch. Commission Corps staff a lot of the pharmacy at the hospital. In terms of subspecialties, there aren't any that are available on a day-to-day basis. Cardiology comes maybe like once every 2 weeks. They'll do like echoes one day and then see a lot of patients in clinic the next day, and then that's really it. ENT was available, but that's wasn't really available the second half of this year, and I think COVID had a lot to do with that. Ortho comes also about twice a month. And then we did have a podiatrist in-house, but that unfortunately fell by the wayside. And it was unfortunate because podiatry is a specialty that I think is very much needed, especially in this population, as I mentioned, with diabetes and a lot of complications that happen with that. So in terms of nephrology, ID, no ICU care. We don't have an ICU at this hospital. So a lot of this high acuity needs, we ended up having to transfer those patients if they felt like their care was becoming out of the scope of just the hospitalists. In terms of labs and imaging, so a lot of labs are done in-house at the hospital, which is great, but cultures aren't, which makes it hard in terms of managing patients and dictating duration of treatment. So a lot of times blood cultures are obtained or urine cultures, and they're sent out to a different lab in North Dakota, and turnaround time is usually about 5 days. Sometimes it's longer. And so you end up treating the patient kind of blindly. You may start broad spectrum, and it makes it a little bit hard when it comes time to discharge if you don't have culture results yet in terms of what oral antibiotic may work for the patient. So that also created an extra layer of difficulty in terms of patient care, because a lot of patients, once they feel better after a day or two, they want to go home. And so it's a lot of discussion and convincing patients, hey, I understand you feel better, you want to go home, but in terms of your long-term management at home, not having all the data can make it a little bit challenging, which is something that you can definitely face when working in a global health perspective as well. In terms of imaging, similar to what Andrew had mentioned, we had x-rays, CT scan, but no MRI as well in-house. So really just your basics. And so if someone was needing a more specialized test or needing an MRI to really determine osteo or not, for example, that required a prior auth, which can take about a week, or you end up transferring the patient to Rapid City, which is, they had a regional hospital there that we had a relationship with, where a lot of our patients got transferred to. So it's a little bit on the inpatient side. Outpatient, there are 4 clinics that are located on the reservation, one in Pine Ridge, which is the biggest, one in Kyle, Wombly, and La Creek. They are staffed by usually one physician. Well, in Pine Ridge, one physician, and then maybe about 6 or 7 PAs or NPs. And then in Kyle, Wombly, and La Creek, usually one physician and then maybe 1 or maybe 2 NPs or PAs that help. They did have optometry at a couple of them. And then in terms of lab and imaging, some of them can run some in-house tests, but a lot of times that data collected was sent again to Pine Ridge to be analyzed. In terms of imaging, I forgot to mention we have one radiologist for the hospital, and he is also the main radiologist that covers a lot of the outlying clinics when they do imaging. Otherwise, when it's after hours, you have to call like a consultant service that looks at the imaging and then can give you a read report, but they're not on site in Pine Ridge. So sometimes it can make it a little bit challenging in terms of getting imaging read in a timely manner, because if you have just one radiologist during the day, he's focusing a lot of times on, traumas or concerns that are coming in through the ER. So it can kind of delay a little bit of you being the hospital as getting the information that you need in a timely manner. In terms of community services related to health, there is a nursing home, which I found to be, so there's a huge population of elderly in Pine Ridge that unfortunately end up taking care of their grandkids or great-grandkids because their parents are unfortunately in jail or on drugs, and so they're not always, or CPS is involved and the parents can't take care of the kids, for example. Saw a lot of that. But a lot of the elderly are in need of care themselves, and being grandkids are not always able to provide that. So when we saw a lot of patients on the inpatient side we felt would benefit from nursing home, it was very much a taboo, unfortunately, in terms of conversation with families and trying to help them to understand, it's not abandoning your loved one in terms of putting them in a nursing home, but it was definitely a discussion that I found much more difficult to have in this community than where I was when I trained in St. Louis. There is a nursing home. It's not physically on the reservation. It's actually in White Clay, which is a town that's literally 2 minutes south of Pine Ridge in Nebraska, right across the border. And that was open in 2010. So it was helpful to be able to have that available because it's designed to serve really just the Lakota population, which was great. Otherwise, you're looking at nursing homes further away in Pine Ridge or in another town close by in Martin. And so it's further for family members to visit. And so there's usually a hesitation for them to want to have their family members placed at those facilities. In terms of ambulance services, so there are only 4 ambulances on the reservation, and they service the entire reservation, which can get really tricky in terms of if you have patients on the inpatient side or even in the ER that need transferring. An ambulance goes off the reservation and transfer the patient to a high level of care, such as in Rapid, or maybe 6 hours away in Sioux Falls if there's no opening in Rapid. And that ambulance has to come back before another ambulance can leave to be off the reservation, in order that there's an assurance that they have at least enough ambulances on the reservation to serve the reservation population, and then still be able to appropriately transfer patients in a timely manner. So that can sometimes be a challenge. Again, I didn't work in the ER, but I know it was the challenge that they faced more in the ER than we did on the inpatient side. They do have, I think, 2 or 3 flight teams, one of them that is Lakota, and then the other ones are kind of outsourced, I should say. And so that was at least helpful to have that as another option if the patient really, more emergently needed to be transferred, then you could at least fly them out. But if the weather wasn't great, then obviously that made it a challenge too. They had community health representatives. They're not at all the same, like what Andrew explained with in Alaska, but they were available really more for transportation within the reservation. A lot of people, as I mentioned, being unemployed, and therefore unfortunately don't have transportation from their homes to the hospital and back. And so they helped to serve as vans to take family members who lived 10, 20 miles away from Pine Ridge, where the inpatient side is, to get back, to Wombly or Kyle, any of the other towns, I guess I should say, on the reservation. There is a dialysis unit. It's not in the hospital. It's a separate building outside of the hospital. But again, there's no nephrologist on site at a dialysis unit. And so it's telemedicine, and it's mostly the nurses who manage that. And that was not the responsibility of the inpatient hospitalist. And there is a VA clinic, which I thought was great to have. It's not very huge, but at least having that for the veterans on the reservation as well. There's organizations for victim services. You do see a lot of intimate partner violence, unfortunately. And then I always mispronounce, but Inpatient, they are rehab that work with opioid patients who are suffering from opioid abuse or alcohol as well. They're wanting to go through rehab. Unfortunately, as we see with a lot of other patients, you will have people who will go through rehab multiple times and then will relapse. As I mentioned, alcohol is illegal. So a lot of times, if people are caught drinking, they actually are just taken straight to jail, and they kind of spend a night or 2 there to detox, and then they're discharged from jail, not so much always brought to the hospital. And then unfortunately, a lot of people make bootleg alcohol, which I don't know all about it, but it's not safe, at least that much I can say. And so you do see a lot of people who suffer from alcohol poisoning as well. These are just a few more pictures. I know when COVID came out, I don't know if any of you heard about some of the reservations. This one, and at least the Cheyenne River Reservation, they had established roadblocks going on and off the reservation to prevent a lot of outside travel on and off the reservation, to limit how much COVID-19 could spread. And I thought this was actually a great effort by the tribe. It was, the governor of South Dakota was not happy about it, but I thought it was great because it helped to really slow down in terms of how quickly we were expecting a spread to happen with COVID-19. And especially because a lot of people live in trailers, and it's multi-generational. You might have 10 or 15 family members that are living in one, like 3-bedroom place, or 7 family members in a 2-bedroom place. And so in terms of social distancing, very hard to do. So I thought this was one effort that the tribe put in place that I think really made a difference in terms of giving the reservation the time to really prepare as much as they could for COVID to eventually kind of show up on the reservation. So with a little bit of everything, I kind of thought about some of the challenges that were faced, and then how that could also relate a little bit to global health. But I think the biggest thing was really a lack of dedicated and regular staffing. I think that made it hard in terms of being able to do the work. One, you are at risk of overworking the physicians that are available and the providers are available, and burnout can easily happen. In terms of having adequately trained providers, especially from my experience and encountering some of the ER providers, that was a challenge as well. But I always thought it's better than not having anything. And so that was one big thing that I know I faced. So especially support, which I thought would have been really great for this patient population. We saw a lot of patients that were suffering from a lot of liver disease complications, like I said, with diabetes, a lot of patients that were suffering from a lot of cardiac issue complications, and then a lot of patients that required ICU care, but unfortunately we couldn't provide that for them. And so transferring patients was something that was new for me to do, because from residency, I was so used to having other outlying communities transfer patients to us. And so this was a new challenge that I had to face. And it helped me to grow a lot in my skills and being able to determine when my skills as a hospitalist kind of stop and you need a specialist on board, and timing it adequately to where you can set up transport. You have to call and get an accepting physician, and then again, being able to get ambulances or the helicopter set up in time. I remember once I had to transfer a patient for vascular evaluation, and she was accepted at 9 a.m. and the ambulance didn't show up until 6 p.m. So from that case, thankfully she wasn't crashing. And so it's something you can manage throughout the day while waiting for transport. But in the winter, when the roads aren't great, it just delays it even more. So it's a lot on the hospital and even the nocturnist to taking that ownership and trying to determine how well can this patient be managed here and stabilized before they're transferred versus do we just transfer from the ER? And so that was a constant conversation with the ER and the hospitalist. We did have a lot of patients that had a long length of stay in the hospital, and that's mostly for IV antibiotic infusions. Unfortunately, there aren't like infusion centers on the reservation, and they can't do home IV antibiotics as well. A lot of people don't have electricity, running water, things of that nature. And so you do have to take those things into account, which again, I really never thought about in residency, but made a huge difference in terms of the care for the patients, in terms of the care that was provided for our patients. And so you'd have people who stay in for 5-6 weeks, and it wasn't fun for them, that's for sure. Especially if you're in isolation too, you kind of feel confined to your hospital room. And so you can think about the psychological effect that can have on a patient, not being able to see their families or really have visitations as easily, especially once COVID happened, when you kind of implement some of those rules. And then I talked a little bit about the nursing home. The hospital, unfortunately, got in trouble with CMS in 2017, end of 2017, 2018, actually, I believe. But thankfully, they were able to go through evaluation and they got reaccredited for through CMS and Joint Commission recently. And it makes a huge difference because this is the only hospital that's available to this huge patient population. And if there's a risk of shutting down this hospital, for example, then that population essentially goes without inpatient service. And you have the clinics, but they can only do so much. And as I mentioned, with transportation being an issue, it was really important for the hospital to work on a lot of the issues, which unfortunately circled more around the emergency room, but they were taken care of to really show that there is a need for this hospital in this area. I talked a little bit about some of the public health issues, like I said, overcrowded housing, limited in terms of running water and electricity. So you can imagine what the summers are like. They're really hot. I wasn't expecting it to be that hot, but it gets like 99 degrees. And so you have the elderly in their home, no air conditioning. There's, risk of heat stroke, dehydration. And then in the winters, there's a lot of risk of frostbite. You have a lot of like a high homeless population, unfortunately. And so people are out on the streets a lot. And so there's risk then of hypothermia as well that I saw a couple of times with some patients. Unpaved roads, which you don't really think about, but makes a difference. When it rains a lot and it gets muddy, people can't drive and get out of their homes to come to the hospital. So that makes a difference in terms of coming to your clinic visits or coming to pick up your medications as well. Stray dogs, I just put that on there because there were just a lot of stray dogs on the reservation. And we did see a lot of people suffer from dog bites. And so you're always worried, well, do I need to worry about rabies or not with this population? And so that was definitely something that wasn't anything I trained for, like dealt with a lot in residency, but had to deal with a lot on the reservation. Health literacy, I know we face that a lot no matter what patient population we work with, but it was something that I noted to be a huge issue in terms of, one, communicating to this population and culture that I've never been in. And so you have to think about, your cultural competency as well when you're working with this population, which is something that can translate into doing global health work. But being able to speak at a level that the patient's able to understand and not feel like you're being condescending. So that was important to be able to delineate, and really being able to understand cultural cues from the patient population that may not be something against you, like a firm hand, something that's seen more as negative in their culture, for example. And I talked about drug abuse a little bit with meth and intimate partner violence. Unfortunately, we saw that a lot. There are a lot of young moms in their teens as well, and then a lot of abuse that happens with that, and then homelessness, as I mentioned. So these were a couple of other public health issues that I had to deal with as a community, and that spill into the social aspect of taking care of your patient on the inpatient side too. Just a couple more pictures. This is the downtown in Pine Ridge. It's not very downtown if you think about like Seattle's downtown compared to this, for example. This is one of, I think, 3 gas stations, and you can see 2 gas stations here. And so to me, this was, again, a culture shock. And that's something that I think no matter where any of you end up going in terms of doing your global health work, to really do as much research as you can in terms of that community before coming there, so you can find a way to really make yourself, I don't know if assimilate's the right word, but really integrate yourself into the community, because it makes a big difference in terms of taking care of the patients in that community. Just a few more pictures. It's a very beautiful landscape. If you've never been, you should find time and go, is what I have to say. A few things, again, really learning about the culture while you are in a different country, or again, even if you're on a reservation, it makes a difference in terms of how you approach the patient population and how you take care of them and how you discuss bad news with them, how you discuss good news with them. This picture on the left is a star quilt, which is something that's very important to their culture, and they give this as gifts to a lot of people that they hold very dearly to their heart. So there's something that, you know, someone offers you that as a gift, and that's like a great thing to get. Just some jewelry that they make on the reservation. There's like porcupine twill that they use to make that. You also have to learn a little bit about like other ways in which Western cultures influence there. So like I said, there's a huge Catholic presence, but as you can see, they still find ways to really incorporate a lot of the Lakota culture into kind of the, I guess, Western world culture. Sage burning, this is called smudging. They do that a lot when you visit like homes with some of the elderly, or really just anyone, if there's any ceremonial activity they have to do a lot of smudging, and that's the word of the evil spirits, which I think is something different from like my culture that I didn't know about. This is me when I first went there, and this is Dr. Jason Bessie, for any of you who know him. He's at UW, and this is his friend Lisa Ironcloud, and we went to visit them. And in terms of, I just want to put this picture out there to show we were making what's called wasna, which I've never heard of, never tried, but it's this root vegetable, timsala, which you dry and then ground up, choked cherries, which I'd never heard of before. You freeze and mash, and then dried buffalo meat, which is really good. It's like eating beef jerky, but better, I thought. And you mix that together, and it's like a nice little snack. So it was interesting to get this experience early on, but this was really it for me, unfortunately. The reservation, in terms of, like I said, there's not restaurants and things where you're also exposed to that food culture. So it's really more from being in the homes of people where you can really get this experience. And I think that's something to take into account when you do go on your global health trip, to find your ways to integrate with the community and the families as well. Some books, if anyone is interested in learning a little bit about the Lakota culture as well, and pretty pictures. That's my dad with me. Just trying to show that. But I think for me, the biggest thing was really just taking into account the culture. And that was how I felt was a good way for me to approach my year in Pine Ridge, because it's something that you don't want to come in with the idea of I'm here to save people and change everything because you're doing things wrong. But it's really about I'm here to support you. So what are the issues that you see in your community? What are the things that you're trying to fix, and how can I be of help? And so I think that's a great attitude to always approach, no matter what community you're coming in to take care of, in showing that you're not coming with great American ideas, but really just humbling yourself and incorporating yourself into that culture. That's all I got. Some pretty sunset pictures. So,
Thanks, Joyce. Appreciate it. So I think we actually have to end at 11:30. So I just want to make sure our other panelists had some time to chime in about their own experiences and maybe chiming in specifically about their relation of global health and rural health and any sort of interventions that you think could be applied to more global setting. And then we can also open it up for further discussion. But Kylan, Megan, and Andrea, just wanted you guys to chime in.
Sure, I can start. I think going along with what Joyce just mentioned, in Alaska, there are 229 federally recognized tribes. And so the experience of working with each individual is very diverse. And I think that that's probably one of the most enjoyable aspects of working in Alaska and the system here, is really understanding, how we can adapt our approach to medicine to best serve the unique values of each individual person, and understanding that each person is coming from a different place and a different understanding of medicine, and how we can really tailor our approach to best serve each patient.
And I would just add, I think in addition to some clinical similarities, and I think that Andrew did a really nice job outlining community health aides in Alaska, which I think is relatively unique in our setting here in the US. Two similarities I think that come across are between my experience in Alaska and less in Anchorage, but really out in Bethel and out in kind of the bush in Alaska, and in Kenya, were a lot of it related to healthcare providers from the outside kind of being very transient. And so I think one thing I enjoyed a lot about my fellowship experience was that we at least had a year that was dedicated to being in a community, because as Joyce said, it took, at least in Kenya, it took, the first 6 months really for me to build some social capital and feel like I was invested in the community and just kind of being present and showing up every day. And I think in Bethel, as a first-year fellow, I spent only 3 months out there, and I truly think the hardest part about working in Bethel was not the medicine. It was really trying to gain any trust, not only within the patient population, but within the kind of providers that I was working with, because they're so used to seeing people come for short amounts of time and then leave. And so I think one of the hardest things that we deal with is really trying to establish that relationship. And so I think there's a lot of value to programs that have longstanding partnerships. And then, I think the other thing too is, a very broad similarity between, my first and second year of the specifically, rural and then global experience is coming in as an outsider to populations that have essentially been colonized. And so I think there are similarities that can certainly be drawn between, Native American populations, and specifically I was working in Kenya, but, populations across the world where essentially they've been forced into a different system. And so being aware of that and being kind of culturally humble, I think that's kind of more skills. Being adaptable and open and kind of being culturally aware is probably the best skill that you can bring with you to any different site. And so I think those are probably the two kind of broadest things. I think often about my time in Kenya, I was thinking what Andrew was saying too about discharging patients. I think in Kenya, and this is not unique to that experience, but there's discharge inns where patients essentially can't pay their bill and stay there. And in many ways, I feel like we have a discharge inn in Anchorage, not because of payment, but because of placement. And for a lot of our patients, essentially, they come to Anchorage, and anyone that requires dialysis, they have to move to Anchorage. If they require any close specialty care with any amount of frequency, they have to move to Anchorage. And for people, this is leaving a community they may have lived in for 80 years and essentially just feeling like they're leaving home. And so keeping that in mind too.
Well, yeah, so I'm just going to kind of echo some of these themes about cultural humility. I think that's a really great way to put it. So my second year in Peru is not necessarily, I did a little bit of shadowing in the hospital, but I mostly did research. And I was doing research on the healthcare system there. And I mean, I think one of the biggest things that I learned was that, or realized once I got there, was that I knew nothing about the Peruvian healthcare system, and I knew nothing until I saw it. And I think it was the same in Pine Ridge. Like, I thought I knew something about poverty coming out of residency, did residency in Boston, and I thought I knew something about like drug use and addiction, and I got to Pine Ridge and it was just, I realized I had so much more to learn. And I think those things are really two like very important tenets when you're going out and doing work in international settings, whether it's medical work or development work. And just being patient and taking time to learn who you're working with, what type of system you're working with, all the complexities and nuances, and kind of accepting the fact that you're always going to have more to learn. I feel like if you don't do that, then you're just going to come in and make changes that you think are good or appropriate, but that might not jive with the people there. And at the end of the day, it's not going to be anything sustainable or lasting. Yeah, those are kind of my thoughts.
Thanks. Great. I would like to open it up and see if there are any comments or questions from the crowd. I mean, I think I'd like to know too, just how your experiences, especially for those that are fellows and maybe moving on to other things, like how your experiences working in especially rural areas are going to kind of transform your practices going forward with your patients.
I guess the first thing that comes to my mind is, so it's interesting, I'm transferring back into a much more urban setting and a place with a lot of resources. And the past few months I've also been working on and off in like a refugee camp. And I feel like, you know, your questions, you become much more comfortable with uncertainty working in these places where you don't have like your culture results, or like, I don't know, in the refugee camp, you're like, do I even have metformin? Like, I don't even know what medication I have right now. And anyway, I think I'm going to carry that idea with me. But I think one thing that I've been thinking about a lot is just kind of transferring back into what we would consider maybe like a normal medical situation, where you're able to get all the data and you have all the treatments and all of these things. But, you know, I think it's important to remember that not everybody has all those things. And that maybe sometimes the way we approach our patients, you know, I think when you don't have all those tools, it forces you to approach your patients a little bit differently and maybe a little bit more holistically. And so I think that, yeah, that is certainly something I'm going to take into my practice.
For me, I think something to consider, depending on what, I'm not sure what specialty you're in or what you go in, is if you do get that call from that small community hospital where they want to transfer a patient to you, being able to understand, this at least gave me that experience to understand where they're coming from. Because a lot of times you're like, well, why can't they just manage that there? Why can't I just give them that there? But I think it gives you a little bit of a different perspective and understanding that people are doing the best that they can with what they have. And sometimes it doesn't mean you want to push it so much to where a patient really decompensates and then, you know, you find yourself in a different situation. So I think that's something that I also took away, is really just understanding when people want to transfer patients, there's a reason why. And it's not just people are lazy or they don't want to do the work, but it's, we've really kind of reached our limits to the safety of this patient. And so we have to think about that more so than saying, oh, we just can't do it or we can't think for ourselves. So that's something that's important to consider too.
Looks like we have a couple questions too. So from Lauren, she said, could you talk a little bit more about the community health worker training and how they get the volume and experience? She said her housemate is in the pediatrics track in Alaska and says they're quite excellent, wondering how they train. So I don't know if...
Yeah, I can take a swing at it, and Kyle, feel free to update. Also on the last question, I agree with Andrea. Sometimes I totally forget to order labs on my patients for like a week. No, but I agree with her, that kind of comfort of understanding how to approach the patient and not just rely so much on diagnostics or one particular care plan, and be flexible is super valuable in both environments. To the health aid question, so my experience is also from out in Bethel. Megan and I were both out there as fellows. And so that's one of the 4 training centers for community health aides. And so pre-COVID, they would bring, so people have to meet some basic requirements. And it's a high school education is the point where they can enter into this. So they don't need necessarily advanced education before doing the health aid training, but by the time they get to the end of it, they can apply all of their health aid trainings towards an associate's degree from the University of Alaska Fairbanks, which is really cool for people that may not have access to higher education. It starts with a 6-week course, and they after that they can, if they do well through the assessments, they can become a CHA1, so the first level. And then they have to accumulate a certain number of case hours in a variety of areas. They need to see a certain number of common colds and diabetic patients, et cetera. And then they can go for an additional 6-week training to go up to CHA2. And different people progress at different timelines. Usually from talking to the health aides, it's like a year or 2 before they're ready for promotion to the next level. And up until CHA and the 4th level, the 4th tier is when they become a community health practitioner. And at that point, it's a recognized licensed care provider under the state medical board. And so at that point, with each step, they get more freedom to make medical decisions and write prescriptions on their own before getting the approval from the physician. And the CHPs function almost essentially as mid-level providers by the time they've reached that stage. That's usually several years into the game with a lot of on-the-job training, you could call it, from having these cases reviewed by physicians and discussed with physicians and coming up with a plan together. And then periodic trainings to advance their skill set. That's my understanding. I don't know, Kyle or Megan, if you have anything to add to that.
I don't want to add, that was, I think, a great training, and I defer to you, Kyle, but I want to add, you can really, the health aides are great. I really enjoyed taking care of them in Anchorage because you'll be talking and kind of explaining what you think is going on, and we'll ask like the best questions. And I feel like there's many times where I step back and I'm like, you were a health aide, weren't you? And then they just have the best stories about what they've seen. Because some people have, there's a really high burnout rate. So, I think there's varying amounts of time that people do it, but may have been a health aide for 20 years in their really small community and have seen all of the, births and deaths, and it's pretty cool.
Yeah, Andrew, that was pretty comprehensive. So basically there are 4 tiers of community health aides. Each one requires a 4-week didactic session prior to their clinical experience. And then they have a set number of observed clinical hours that they have to have in order to meet the certification. So for the first tier, it's 60 clinical hours. And then for every tier after that, it's 200 clinical hours. And then they have a final observation when they become a community health aide practitioner, which is the final certification where they get to function as a regular practitioner with standing orders, being able to administer immunizations on protocols, dispense medications on protocols. So they are really the backbone of healthcare delivery in Alaska. They're amazing.
And I'm just going to add from the question from Catherine Palmer about this too, at least the experience out in Bethel, in the same way that you're assigned a different, clinic to be in that morning, there's someone that's assigned to radio medical traffic. And so it's all done, it's still called radio medical traffic, but it's done through the EMR. And so they have Cerner. And so there's a way to kind of communicate through the EMR. And so it's done in real time. There may be some, delay of, minutes to hour, but it's staffed that morning and they've declared the box.
Yeah, and the radio traffic is triage. So anything that's non-essential goes through the EHR. Anything that's more urgent, they have to call the emergency room or a physician on call immediately to help triage it. So there is some triaging that initially goes into it as well.
Looks like there's one more question from Tess. Since COVID has accelerated telemedicine acceptance and practices, how do those of you working in remote settings see that changing access to care or changing the way medicine is practiced? Or will it change if you're already doing remote work?
Kyle, I think this one is all you about medicine.
So it's Alaska has been on the forefront of telemedicine for a while, but then we started lagging. But really, we've transitioned. We had the infrastructure in place for telemedicine, and we've really pivoted to leverage that a lot lately. Part of the complication is there's still, just in general, there's a lot of fear of going into a community clinic. And so, people are really delaying presentation, and a lot of people are just not coming in for any visits, like acute illnesses are presenting in, severe distress. And a lot of our wellness and immunization efforts have been blunted because of this as well. For example, we just had 2 days ago, I got a call from one of the villages about a 4-year-old who had left-sided facial droop, wasn't moving his left arm and wasn't moving his left leg. Basically, since July, it's been progressive. And finally, it became so severe that he couldn't walk. And so the mom brought him into clinic. The PA called me. I immediately medevaced him into Nome, where we could get a CT scan, and he has a very large brain tumor. And these symptoms have been going on since July, but there was a lot of fear with the family in terms of coming into the clinic because COVID had been going around the community. And so we see a lot of delayed presentation, unfortunately. And the other issue is in rural Alaska, the connectivity is very poor and incredibly expensive. So a basic internet plan will run a family probably $400 a month, which isn't really affordable. And so even though we've tried to leverage direct to patient care, so calling a phone, a lot of individuals don't have phones that are consistently on. They don't have internet where we could use FaceTime or anything else. So in order to leverage the technology that we do have, they still have to come into the clinics, which there's a huge barrier to coming into the clinics. But once we get them in there, we can interact via telemedicine, but it's still not as good as it should be.
Thanks. Well, I know we're at 11:30. I think if people have other questions and want to stay on, that's fine. But I want to make sure that people are getting off to their afternoon clinics and such. But I really want to thank all of our panelists for joining today. I really appreciate you guys taking the time to come and prepare some talks and share your experiences with us.
Thanks for having us.
Yeah, thanks for the invitation.
Yeah, thank you so much.
I'm gonna have to jump off, guys. I have somebody on meth trying to leave AMA, so it's
Okay, thanks, Andrew.
Thursday.
Thank you.
I have a bit more time if anyone has any other Alaska questions, so I'm happy to hang out for just a minute.
Thank you.
Looks like there's also a plug for a New York Times article from the 29th about COVID and the IHS. So I'll make sure to read that.
I just wanted to say hi to Joyce and Megan. Nice to see your faces.
You too.